As we finish up our day, we'll grab a seat for our last couple of sessions. Thank you so much for those of you who stayed. And online, I can see the numbers have switched, so there's more people online now as they put their headsets on. And just remember to keep your videos off on home. I've seen some of you guys hanging out in your pajamas, no problem, but you guys can't see it, I can see it. So the next speaker is Dr. Serena Corsini-Munt. She's an associate professor in the School of Psychology at the University of Ottawa, director of the Relationship and Couple Health or REACH Lab. She is also a registered clinical and health psychologist. Dr. Corsini-Munt's funded program of research focuses on clinically oriented research in chronic pelvic pain, sexual health population. She has actually one of her grad students here with her. And there is a push, I don't know if you'll be advertising. Okay, we have surveys, part of the research project to advertise to all of you. Online, I'll share that separately. We should probably get that link. But I'm really excited to hear from our colleague, because we talk a lot about psychology like we know what we're talking about, but the expert is here to actually tell us what we're supposed to be talking about.
Okay. Oh, well, thank you. Thanks, Tony. So I'm feeling pretty privileged to be here with you today, learning from you. So I've been here all day, and it's been really great, and feeling quite at home and quite welcome, and hearing from all the presenters. And feeling really lucky to share some of my perspective, or perspectives from my discipline, right? Clinical and health psychology. So thank you for having me. Here we go. So one of the things I wanted to add, we've heard our land acknowledgement a couple times today, and one of the things I wanted to add to that is something I usually talk about when I do a land acknowledgement, whether teaching or doing discussions, and that's the practice of Chenchetswe. And so Chenchetswe is a Squamish word, and it means upholding and supporting one another. And I think that's a lot of what you're doing today here, to gathering and learning from one another and being open to hearing different ideas and different techniques. And I usually use it in the context too of being able to share new perspectives or practice correcting each other, right? So if ever we make mistakes or we want to share something, so it's about practicing caring correction and welcoming caring correction. So I like to add that to land acknowledgements and our purpose for gathering. I have no disclosures to make in terms of financial or otherwise, and I haven't received any payment, and the slides were previously shared to help mitigate potential bias. So the learning objectives that were listed in the program are here for you on this slide, and it's really about helping identify and discuss psychosocial impacts of endometriosis for those diagnosed, but also for their partners, and describing the elements of psychosocial supports identified as helpful by this clinical population. So we've actually interviewed almost 50 couples, asking them what they find helpful in terms of support. And then hopefully sharing with you some ideas about what you might look for, how you might interpret potential cues or potential areas that could use or could signal that psychosocial support would be helpful. So referring to an allied professional, referring to a psychologist, social worker, or a psychotherapist. And I mean, I'm really hoping in general, and this is a less measurable objective for today, but really hoping that in sharing some of what I'm going to talk about, that you feel validated in working with this population, and that hopefully that validation helps free up some of your emotional resources to be more available to your patients. So some framework for us today and what I'm talking about. So I approach all of this from the lens of a clinician and a researcher. And in my line of work, we call that the scientist practitioner. And so Sony mentioned already, so I don't have to repeat to you what it is that I do. But in my practice, I'm both clinical and health psychologist working with individuals, couples, adolescents, and families. So I really take a holistic perspective in who I'm working with. Today's presentation is going to have some framing using the biopsychosocial model of health, which is this beautiful Venn diagram that I love so much, that really captures both those aspects of psychosocial or psychology and social implications with the biological components. Stemming from that, we borrow a lot in our work from the communal coping model of pain catastrophizing, right? And this idea that people are looking for support sometimes in their communication of what they're experiencing, and the empathy model of pain, and also self-determination theory. So I really liked hearing about autonomy earlier quite a lot. So I'm going to include information that comes from the literature, peer-reviewed, but also relevant gray literature, and some data from our group as well. So I don't know if these drawings are new to anybody, but the drawings that are here on this slide and the next couple of slides are from a research project from Cardiff University, where they gathered their participants, so all from Wales, and they had them draw and speak to and write about their experiences with endometriosis. And then they put together this both beautiful and jarring PDF package that you can download that really highlights what these individuals are going through, and really capturing that in artistic format. So I don't know if you're having the same reaction that I have when I look at these, but I find them quite emotionally evocative, but also consistent, right, with what patients have expressed, in that the pain associated with endometriosis clouds almost all of their experiences sometimes, especially leading up to trying to get that diagnosis, or in trying to find appropriate management, or in dealing with health professionals, but not just health professionals, members of their family who don't validate them, who don't believe in them, their partners who might not be supportive, employers and work settings as well. And it contributes to a profound discouragement. And what we know from the literature too is that when pain is higher, we often see higher rates too of depression and anxiety and lower quality of life. So those things are amplified when we do have higher pain. And the frustration that individuals with endometriosis express about the healthcare system, or having encountered healthcare professionals that were not well informed about endo, I'm sure is shared by all of us, right? I think that's an almost ubiquitous experience that we hear those stories. And there's sometimes that frustration is leveled towards us, right? Even, right, we're part of that system sometimes. And that can be challenging, right? I think Sonia and I have talked about that too, about how to handle that. And the result is that for many patients, these systemic challenges and delays compound their distress. And that's what we're meeting in those moments, is that high level of distress, that sense of helplessness, that sense of panic that accompanies their pain, and that in addition compromises that timely medical management, but also what might be timely cognitive behavioral management, right? So the role of a psychologist, or the role of a health psychologist, and I'm jumping ahead a little bit because sometimes people say, well, why do I need to see a psychologist, right? Are you saying that my pain's all in my head, right? And that's a delicate conversation to have, but it's important to let people know that a psychologist isn't because the pain is believed to be imaginary or some sort of sublimation, but it's this idea of helping them cope with their pain, right? And the impact that their pain has had, and that there are evidence-based ways of helping them face that pain, and even help bringing pain down sometimes. What we also see, and this was, and I'm still showing images from this PDF, and are the slides? The slides will be shared, so you're able to access the link for the PDF that's on all three of these slides. But what's also across different research, or different types of research, both qualitative, quantitative, and even this project as well, is that partners, romantic partners, end up being identified as a source of support, with patients bringing their partners even to appointments and feeling as though their partners can help advocate for them. How many of you have had partners come to appointments? Yeah. And how many have experienced a partner speaking up for, yeah. And so that can go different ways, right? Because sometimes we want to hear from an advocate. We like to see that our patients are well supported in their lives. And at other times, we are trying to figure out where the patient is in all of this, and whether or not we're meeting their autonomy needs as well. We also have seen that in specifically, and I have a student here who's studying this, empathic processes in both relationships with partners and with physicians. But a partner's empathic concern has been associated with higher relationship satisfaction for both members of the couple. So, and that shouldn't be too surprising. We should expect that even in couples that are high in satisfaction without clinical presentation, without chronic pain. But it becomes particularly important when there is chronic pain, right? That a partner has that capacity to be empathic, especially when that pain is as recurrent and chronic as it can be with endometriosis. So in terms of impacts or exacerbating and maintaining factors, that are documented in the literature, I want to highlight that anxiety and depression are often present, not always, but often, and typically associated with higher pain intensity and lower quality of life. And it includes also role challenges, right? So challenges in terms of work productivity, challenges in terms of what we like to call work in the home or homework, division of labor in the home, taking care of children, right? Who's helping take care of the home, and that we see, or certainly our couples have talked to us a lot about this, is patients with endometriosis worrying about how much of a burden they are to others around them, and that compounding their level of distress and their sense of isolation. And one of the things that we've encountered in some of our research, because we didn't exclude when partners had their own health condition, but how much more this is compounded when a partner has a health condition as well. So now we have two people with chronic health problems and how they navigate the medical care system and how they navigate care for one another. There are repeated reports across samples of the morbidity, symptoms, and pain contributing to sexual dysfunction. I've heard many of you talk about dyspareunia today, and we know that it's not just pain during sex, but it also affects desire for sex. It affects ability to feel aroused, capacity to tap into pleasure, and contributes to, well, a lower frequency of sex as well. So an avoidance of this behavior. And why this becomes particularly important when working with couples clinically is that sex is this, well, in addition, we like to all be able to feel good about that part of our lives, but sex is often an avenue of proximity for couples. And when that avenue gets closed, they might feel further apart. And so that's why it becomes particularly relevant when we see this. There's other robust findings too in terms of psychosocial impacts related to pain catastrophizing. So pain catastrophizing is a combination of rumination, magnification, and a sense of hopelessness. And we see it as a very robust predictor in the chronic pain literature from that move from pain to chronic pain. And we also, in our own work, have seen it function in a dyadic way, so that the pain catastrophizing, the effects of it are relevant not just from the patient who might be catastrophizing about their pain, but how their partner is thinking about their pain as well. So in one of our studies, we found that pain catastrophizing, when higher from both members of the couple, was associated with decreased sexual satisfaction, higher depression for partners, and higher pain unpleasantness ratings for individuals with endometriosis. So we measure usually pain intensity, but we also measure that quality of unpleasantness as well. And so we saw that higher catastrophizing really contributing to that level of distress. Or sorry, I don't say I want to contributing, it is cross-sectional, but being associated with a higher level of distress about the pain. And some other psychosocial considerations that I wanted to mention that got touched on today too. So I feel very validated. I know you will feel validated too, but I feel very validated today too. But is the previous negative experiences in healthcare, which can compound the level of distress or psychological distress of our patients. And that can include invalidation, right? So being sent home, right, when in severe pain, or being told that it's just part of your period, right? And certain amounts of discrimination also. We know that there is a historical neglect of female reproductive health concerns. We also see, and this was mentioned and touched on as well, that in this population, well, in a chronic pelvic pain population rather, because I don't know if we have specific data for just individuals with endometriosis, but we see a higher rate of history of abuse, including interpersonal trauma. And that is, again, it's not deterministic, that having a history of abuse will mean developing chronic pelvic pain, but we do see a higher proportion of it in this group. And I guess I'm wondering how many of you have had a patient disclose a history of trauma? Yeah. How many of you ask about it routinely? That's great. That's really great. We're working right now on we got some CIHR funding for it, so we feel really good about that, but developing some trauma-informed guidelines to help us with that as well. And as we know, facing infertility can be very difficult and worsen anxiety and depression. So typically when we have that element of infertility, that many of our, and I'll talk about this in some of the data that we collected from couples, but there's a lot of grief and a huge sense of loss. And it's sometimes very difficult because it's a loss of something that was to come sometimes, right? So sometimes we call that an ambiguous loss, and that can be very difficult. And then, of course, the challenge in that non-linear arc of treatment for chronic and recurrent pain, and that's challenging, you know, that 2 steps forward, you know, 3 steps backward, 2 steps forward, 1 step backward, that bit of that roller coaster that happens with different management. It can be really challenging for patients, but also for the healthcare provider as well. So part of my program of work and building from other work that I've done working with patients with provoked vestibulodynia and their partners and using cognitive behavioral couple therapy in that context is really about identifying factors and targets for psychosocial support for individuals with endometriosis and their partners. So we can approach this from an evidence-based perspective. So really supporting psychological well-being and mental health and relational and sexual well-being in this group. And we do that in a few ways. We, again, use our biopsychosocial framework. We make dyadic considerations, more and more moving towards patient-oriented research, where we're consulting with patients before we even start data collection, making sure that the questions that we have make sense for them as well, and taking into account perspectives of providers as well. So I think it's important to treat this holistically. We try to do this in a multi-method approach, so we're using qualitative methods, observational, experimental, and quant as well. So, hang on, I'm just trying to, what slide do you see? Oh, okay, great. So, I wanted to present some of our work. I have 2 studies that I want to talk to you about today, and this study that I'm going to talk about uses that dyadic consideration, and we're applying it to looking at sexual motivation. And we're interested in motivation for sex because we know what happens in couples where there is dyspareunia or there's difficulties having sex is some people do avoid it, but many people try to continue having sex, and for different reasons. And so we wanted to look at, in this study specifically, about the quality of motivation or the differential types of motivation and what that meant for our outcomes or what that meant for our dependent variables of interest. So really about the importance of quality of motivation, and autonomy will become clear in this too because we look at it from a self-determined perspective, so really looking at autonomous motivations versus controlled motivations, and I'll explain those. Probably right now is a good time to explain those too. So autonomous motivation in the context of sexuality would be about having sex for its inherent pleasure, or having sex because it taps into values that are relevant to you in a personal sense. And really, if you've heard the word intrinsic, right, they're really coming from you and they're important to you. Controlled motivation or controlled reasons for having sex are really, think more contingently, right? So that they're happening because we want to avoid a fight with our partner, or they're happening because we think it's what we should be doing, or there's a sense of obligation, okay? So we had a sample here of 54 couples. This was a bit of a pilot, and this was something led by one of my grad students who's not here today, but there's a few of them working on this program of work with me. And of our 54 couples, I just wanted to give you a sense, a little bit about them. predominantly in mixed-sex relationships, predominantly cisgender, average length of relationship about 7 years. Among individuals with endometriosis, we had 52 cisgender women, 1 trans man, and 1 non-binary person. And for partners, we had 52 cisgender men and 1 trans man and 1 cisgender woman. That samples what happens when you're not doing purposeful sampling. So that's when you just keep it open. So what we ended up finding was that when persons with endometriosis had sex for more autonomous reasons, right? So for those the inherent joy or pleasure of sex, they were more sexually satisfied, okay? And again, I wanna just point out, you see this arrow is a bidirectional arrow, meaning that this is cross-sectional in nature, so these are associations. So it could be also that we have more sexually satisfied individuals also reaching for autonomous reasons, also for their sex that they're having with their partner. We also saw that when persons with endometriosis had sex for more autonomous reasons, they were more satisfied with their relationship. So higher relationship satisfaction. And when partners, we do this dyadic model, right? So we look at what's happening for both members of the couple. We control for each individual's variables when we do this so that we can look and separate what's happening for each of them and really consider the interdependence between some of this, right? So when partners had sex for more controlled reasons, both they and the person with endometriosis had lower sexual functioning. And when persons with endometriosis, this is really interesting, had sex for more controlled reasons, we're not the interesting way yet, but this is good too. But they and their partners were less sexually satisfied. And here it is. And when persons with endo had sex for more controlled reasons, their pain during sex was more unpleasant. So their distress around the pain is higher when they're having sex for these more contingent or these reasons more out of obligation. And intuitively, that makes a lot of sense. And what it means, though, for us as we go forward with this work, or what it means for us as clinicians working with this population, is that what's happening for both people in this relationship is going to be relevant to outcomes for both of them. So the motivation, we talked about pain catastrophizing earlier, the cognitions and thoughts that partners bring to this as well are important and going to have an impact. And that supporting autonomy or helping people tap into autonomous motivation, helping them reduce their use of controlled motivation is also really important. And we do that by doing autonomy support and helping people with some psychoeducation around that as well. So what I'd like you to take away from this study is that what's going on with the couple and our patient's motivational stance is relevant for our patient. And so continuing along, so in addition to that work where we're starting to identify factors, we also want to learn about what couples find helpful, right? This is a bit more patient-centered, a bit more looking at for them to tell us what is helpful rather than us, developing things and then seeing if it is effective. And so really hearing from them about what has been helpful in terms, and a lot of this work, this one is about to be submitted, so it's not published yet, but I've presented it before to a group of therapists, and I really used it to help embolden their accessing of training about health conditions of their patients and making sure that they're fully informed. So we asked 49 couples coping with endometriosis to identify the psychosocial supports that they thought would benefit, that they knew had benefited themselves, but that they thought would also benefit others coping with endometriosis. And here's some demographics of our sample. And let me just make sure I tell you everything I want to about this slide. So what we did was we applied a thematic analysis. So we went through the interview content. 2 or 3 of us went through it, well, 2 for sure, and then 1 person went through it, a 3rd person went through it again just to make sure, and looked at all the common themes that people were noticing in these interviews. And we collated all of that with a code book, and then we put it together, and these are the 5 themes that emerge. So we see, and they're listed here, empathy and compassion, acceptance and coping, systemic support, sex and infertility and therapy. And then I have some choice verbatim quotations from the sample as well there. So couples spoke to how empathy and compassion have really been integral to their ability to cope, and that learning to harness acceptance allowed them to better support one another and problem solve. And I think we heard that today in one of the other presentations about understanding what it is to have endometriosis and accepting what might be achieved with management. Over and over again, couples talked about their dream of systemic support, which described as comprehensive, efficient, and inclusive care within the healthcare system that would include psychosocial support for them and their partner. And this was really beautiful to hear them talk about this, and really reminded me as I heard them describe it through all the different interviews, a lot like what we see in oncology care, right? Picturing an oncology center, right, which we wouldn't be able to have in every geographical location, but where there is built in already into the model of other professionals, allied professionals, and that referral system is right there for you. Couples repeatedly brought up how they have adjusted their sex lives and grieved their infertility, some sharing how counselors had helped, and others indicating how they wished they could have accessed more formal support to understanding the impact of their fertility, family planning. Couples shared how they worked hard to prioritize closeness over penetrative sex. So when they were experiencing dyspareunia or pain with penetration, how they had prioritized other ways of finding closeness. And the final theme related specifically to therapy. So inclusive of a desire for therapists, sex therapists, couple therapists, group therapy, but that would, even group therapy for partners, with a big focus on the clinician being able to provide accurate information about endometriosis and having knowledge of its impact. So the quote here at the bottom is, "It's just so hard to access a doctor who knows about this that you're wondering how you would ever even find a social worker or a psychologist that would also know about it." So the idea here is the focus on psychosocial support, for us, what we're talking about today too, and we want to be able to help our patients find therapists and psychologists that can help them with some of these things. And that's not always easy to do. Oh, I see what's happened here. Okay. So how do we do that? How do we know which patients might benefit from being referred, which ones need to be referred to a psychologist? How many of you refer to a psychologist? Or social worker, or a therapist, or a counselor? Okay, so some sort of mental health, but not everyone. It's not part of everyone's regular practice. And that is sometimes because not everyone has a network of who they can refer to, or we don't. And so, or sometimes we aren't quite sure what are going to be the cues or the signs to make that referral. So putting everything all together, I want to share maybe some preliminary recommendations that I hope will be helpful. Identifying some of your patients that require a bit more psychosocial support. And so really looking for what we're talking about in the extremes. Because I know that when your patients get to you, they can be quite expressive too already. And I think we're in a good position with the psychosocial model, biopsychosocial model, to make those recommendations. So things we'd like to look for in getting a sense, so extreme emotional distress, especially related to the relationship, because we know that if they're in a relationship, what's going on in that relationship is going to reverberate back and has that interdependence and that connection with how they're doing and how they're going to cope. When we're looking at, we know the high prevalence rate of anxiety and depression, so we're really looking for excessive presentations of that. And some of that can be as easy as asking if a patient is also seeing a psychologist or if they've talked to someone. Some of the measures that I think you use, I think it's in the effect, which is that full compendium of measures. There is pain catastrophizing already listed. So if we see that being higher, we have a good indication also that anxiety and depression are likely higher as well. If there's a lot of grief and resentment relating to infertility or other losses, right? Because there's other losses associated with endometriosis, right? Loss of productivity, loss of relationships that have gone by the way because of the chronic pain. Loss of friendships, loss of connection with family. We've had a lot of couples talk to us about how they avoided going to family functions because family often didn't appreciate didn't really understand them, or didn't understand that they needed to eat a different diet sometimes to keep inflammation down. If you see avoidance or rigidity avoidance or difficulty implementing recommended changes, or almost like a resistance, right? This might be an indication about readiness to change, or that the patient has started using avoidance. Avoidance in pain makes a lot of sense, right? Some things, stove is hot, don't touch stove, okay. But if you do that, that's the only way that someone's engaging with their pain, especially when it's recurrent. They're not working on other types of more flexible coping, and that can be really detrimental over the long run. Rigidity in expectations for improvement, or a rigid focus on one area of functioning to the neglect of others, might indicate that we need to, and if you don't have the time to do it, then referring to someone might be really beneficial too, to have someone else talk to them about what else they might be attending to, what else their expectations. And there's this piece here I have at the end that's similar to that, but focusing just on pain, looking for that zero pain. I want my pain to be completely gone, and neglecting other aspects about ability to cope with the pain, right? Or ability to face the pain differently. And we see that a lot in I pain patients in cognitive behavioral therapy. I'll say, what are your goals for therapy? And they're like, I'd like to be pain-free, or I'd like to have sex with zero pain. And I say, okay, so let's talk about expectations and what we can achieve. And ultimately, we do usually see a decrease in that intensity, or we also see an increase in that tolerance, and able to understand and appreciate and not be as distressed by their pain. But I think that was touched on too in one of these presentations. I felt, it was great to hear all the talks today, but that was also referred to as well about tempering expectations, right? And goals and treatment goals with our patients. So when we see these ones, we might know that there's an opportunity for referral. Other things to think about, that extreme catastrophizing about the pain, body hypervigilance, a sense of low self-worth, indicators that a partner is not being understanding, of course, indicators of intimate partner violence as well, or interpersonal conflict. And those are other things we can look for. The thing is, time is tight, right? I think that got brought up in one of the questions, and some of us in our practice can make time, or that's the focus of our practice, and we can spend time differently with patients. And you shouldn't feel like you have to do it all. I think there is a lot of that pressure, right? Because by the time they get to someone like you that can give them that diagnosis, right, and can give them that treatment, there is a sense that you should be the person that can do everything. But hopefully, I'm okay in doing this, but alleviating that pressure a bit. That we should be working interdisciplinary, we should be working in multidisciplinary teams, and we cannot be everything to them. And some things go outside our scope of expertise. I've had a lot of physiotherapists who are part of an early career group that I'm part of talk about how patients bring to them, their patients bring to them trauma experiences, right? Because of the nature of the work, they're one-on-one, there's a physical component as well, and they don't know what to do. And they're not quite sure, and they'd prefer, and they're actually not sure they really want to learn what to do either. And that's okay, because there is a self-selection for everything that we're all doing and working towards. But the things we can do without necessarily adding more time, right? This came across today too, is validating patients' experiences. We may not always agree, or we may know that there's different experiences. We may find what they're bringing to us extreme, but I think we can tell them that it's understandable how they're feeling. Even if we're not comfortable saying, I understand, right? We can say what they've gone through, or their discouragement or their distress is understandable. We can try and address some of that pain catastrophizing by little ways of helping pain self-efficacy, so helping increase their sense of control or their confidence in what they can do. And we can do that with some psychoeducation, which I'm sure a lot of you do a lot of in your practice, but making sure that they are informed. We can try, this is a balanced thing, try and promote acceptance versus resignation. So when we see someone who's feeling resigned to their diagnosis, try and promote a more, and it's a very subtle thing, but try and talk more about, I guess this comes back to this idea of giving hope, but understanding that they are not, even though they often feel defined by their diagnosis, they are not necessarily, it's not the only thing about them. We can promote autonomous motivation by offering choice when possible. So this can include learning what is important to the patient, right? Fertility, preservation, or the functionality that they want to get back to, or they want to get to that they never were able to have in the first place, and promoting their autonomy through shared decision-making. And I think this is, we're wrapping up and coming to this point about offering leads for specific supports. So building that network of counselors or psychologists or social workers that you trust, that you know will provide good support, that have knowledge of endometriosis, that will be able to understand so that this patient doesn't have to explain everything about their disease to their therapist. And that's really important. And that's not easy to do, right? And I say, oh, go build relationships, go make some friends. So I actually am starting, I have a list that I've shared for Ottawa, but I'm now putting together a list of individuals in Ontario that will do virtual services, and I can extend that further, and we can help partner with SOGC to make sure that's available. So you can do, now again, not everyone will be able to access private practice therapy, but some people will be able to, and sharing that list. So let's see what's left. Oh, yeah. Participant recruitment, and the participants are you. So part of our work is really ensuring that we're getting, I have this dyadic focus, right? This idea of working with both members of the couple. So we also want to work with physicians too when we're trying to understand patients' experiences, because there's another side of that experience, and that's your experience as well. So the first poster is for a study looking at the thing that can facilitate being empathic in your interactions with your patients, or the barriers to doing so. So really focusing on empathy processes, and my graduate student Elisa is the one heading that project, and I think we're going to be able to share that on the listserv with everyone very soon. The other project is led by Dr. Lauren Walker, who's in Alberta, and she's looking for healthcare providers to comment on trauma-informed guidelines for pelvic health. So not necessarily specific to chronic pelvic pain, but it's another project looking for providers, looking for you. So I wanted to do a plug for those. A list of references that were used for this presentation. A huge thank you for your time to Dr. Singh, an important acknowledgement for my graduate students and their dedication to our shared program of work, focusing on autonomy, support, health, and relationships, and a deep appreciation for our participants as well. Thank you so much.
Great, thank you so much.